Hey, DNA. On this episode of All Access DNA, we are talking about childhood and adolescent obesity and the impact of genetic factors. I'm your host, Kate Wilson, and I speak with Dr. Evan Nadler, a leader in this field who has authored multiple publications and textbook chapters on the topic of pediatric bariatric surgery and was one of the founding members of the Childhood Obesity Committee of the American Pediatric Surgery Association. Dr. Nadler talks about moving away from discussion centered on shame and blame to reframing the childhood obesity conversation with genetics. Let's get started. Thank you, Evan, so much for joining All Access DNA. I've actually been really looking forward to this conversation and learning a lot more about this area.
It's my pleasure. Thank you for having me on. Happy to be here.
Awesome. I think best to just kind of dive right into it. You're an expert in childhood obesity. Can you tell us more about what causes childhood obesity? Is it just genetic? Is it due to lifestyle and diet?
Yeah. So I think one of my sort of taglines that I like to mention sort of at the beginning of lots of these sorts of podcasts or other appearances or whatever is that first, it's really important to understand that obesity is a disease and not a lifestyle choice. So no one chooses to have obesity and no one really eats themselves or sedentary lifestyle themselves into obesity. There's always other driving factors that contribute to the development of the disease. So specifically to your question about what causes obesity or what causes childhood obesity, especially in children, if you think about it, they're not really even on the earth long enough for the outside influences or the postnatal environmental influences, postnatal afterbirth, meaning influences to impact their disease as significantly as it would be for a 40-year-old who's been exposed to all these other potential contributors. So with kids, it's really a combination of their genetics they inherit from their parents, their epigenetically modified genes, which is a mouthful, but basically what it means is that there are so epigenetics is the field of gene modification, and it doesn't change the sequence of your DNA. It just changes how your DNA is expressed or translated into proteins. Again, I don't want to get too technical or scientific here, but basically epigenetics or epigenetic modifications change how your genes sort of function and what they do. And then it's a combination of those things, plus the maternal utero environment and maternal health during pregnancy also plays a huge role. So it's a long-winded way of saying there are a lot of different things that go into development of obesity and especially childhood obesity, a lot of which we're just learning about now or just really getting to understand now. And so I think the main take home is that it's not anyone's fault. It is just another disease that people get.
And like with a lot of conditions, probably it's a combination of multiple things, and it's not always very black or white or binary. There's a confluence of different things that can contribute to it.
People in general don't like gray. People like black and white. It's a lot easier to say ultra processed foods are terrible, not say, well, some ultra processed foods are okay. In fact, some ultra processed foods are actually really good, but that's too confusing because then it's like, are they bad or are they good? It's much easier to say they all are terrible, so get rid of all of them. But that's actually just not the reality of the world, pretty much with any disease, but certainly not with obesity.
Well, and I think what's interesting, you mentioned, epigenetics. So it used to be that those in the genetics field, and I think the general public think like, I have this gene or I don't have this gene. So it's, again, either or. And genetics really is not that way. And so like you said, there are some which we call like Mendelian genetics, Mendelian traits, where you maybe have a mutation or you don't, but a lot of it is a combination of different genetic changes, so actual DNA sequencing. But then like you mentioned, epigenetics is sort of like, how are the genes being regulated? What's being flipped on? What's being flipped off? How does this gene impact how this other gene works? And so with those epigenetic factors, it adds even another layer potentially of nuance or complication, trying to kind of tease out what's going on. I was wondering if you could tell us a little bit more about like the in utero environment, because I know working as a genetic counselor, we would sometimes talk to patients like if they had certain teratogenic exposures, so things that would impact the growth of the fetus. So some things can make a fetus grow larger than expected, some can make them grow smaller. Can you tell us a little bit more about how the in utero environment plays a role?
Yeah, no. So the people sometimes ask me like if I had to sort of change one thing that could help the obesity epidemic slow. We're never going to reverse it, but if, let's say we could slow it down or at least get it to a lower number, what would I do? And the answer I give is that I would actually focus on sort of young parent health, maternal fetal health, and also the dads. The dads can't get ignored in this equation. And the reason that is that the in utero environment, which everyone's already sort of always sort of understood, like shouldn't smoke during pregnancy, shouldn't drink alcohol during pregnancy because that can negatively affect your baby. But it hasn't been until somewhat more recently where we now know that if you have gestational diabetes or if you have pre-gestational diabetes, meaning just diabetes type 2 from before you were pregnant, the likelihood of your child having obesity or having type 2 diabetes as a child is hugely increased. And actually, there was a paper published a couple of months ago that even showed that maternal diabetes or maternal prediabetes increased the risk of having autism spectrum disorder by like 20% or something like that. So we're learning, and there's this whole connection between insulin resistance and the brain that people are just starting to get a handle of, and Alzheimer's disease is being called type 3 diabetes. So there's a lot of metabolic interplay between the whole body and the brain, which we don't understand. But the point of it is that the in utero environment is far more important than I think has been previously recognized with respect to metabolic health.
Hmm.
And we've always known it was important for teratogens, for instance. I think thalidomide was the sort of poster child of teratogenic medications, but it's now recognized that the in utero environment is increasingly important. And I guess there was another study that was published that showed that sugar exposure during the first 1,000 days post conception. So that's like 300 days in utero and then 2 years ex utero or after the baby's born was, significantly tied to, again, adolescent type 2 or childhood type 2 diabetes and childhood obesity, which again just shows you how important that early stage turns out to be.
Mhm. Well, and it is I appreciate you saying, like, there's things that we still just don't know and that we're still learning, right? Because that's the whole point of science investigating is finding out more, learning more. Some of the things that we're able to look at today, we weren't able to look at 20-ish years ago. So, it's still things are being uncovered. So, in knowing that genetics does play a role, even, epigenetics and environmental exposures, how does genetics play a role with things like diet and exercise? Because that's kind of one of the things that you hear about when people talk about obesity. Does genetics totally overrule diet and exercise, or do they work together?
Yeah, it's an interesting question. And actually, I think one of the things that people don't even necessarily think about is that it could be your genetics that drive you not to exercise, for instance. Maybe I'm giving our genes too much credit, but maybe we have more free will than is predetermined. But I think, like when you talk about like what makes it so that people, either love exercise or hate exercise, maybe it's genetic. Anyway, the that might be too philosophical for this particular discussion. But no, obviously, genes are modifiable, which is what we just talked about with epigenetics. So if there can be environmental influences such as, let's say, ultra processed foods, like we talked about before, or the forever chemicals or plastics that can negatively impact epigenetic modification, diet and exercise are thought to be able to positively impact it. So I think where we can sort of make an impact is that, let's say you have a genetic predisposition to obesity. And there's I like to quote studies. I pay attention to the scientific literature a lot. And there was something recently that 8 sort of subtypes, gene clusters, they were sort of identified in different subtypes of obesity, published relatively recently. And I think the way these sort of gene scores can be used is that you identify people who are at risk, and then you can implement diet and exercise earlier. Like if you knew your kid was highly likely to develop type 2 diabetes as a teenager, you probably would start at age whatever, 3, 4 with the healthy behaviors that might prevent that from happening. But right now we just don't have enough, and the scores aren't really out there, and the genetic testing isn't quite available enough or even really quite good enough to know exactly who those patients at risk might be.
Mhm, mhm. So I think you're talking about maybe those polygenic risk scores. So I know we've
Mhm.
chatted about them like in the cancer realm, but they can be
Right.
applied to these other areas. But like you said, it's still kind of early days at this
Sure.
point.
Right. And there are
Okay.
single gene defects that cause obesity that we know about, but those are much rarer. And there are syndromes that are associated with obesity, again, much rarer. So the polygenic risk, I think previously it was thought that the, sort of environmental obesity was really environmental and not related to polygenic risk. I think those ideas are sort of fading. I think everybody sort of has their own, let's say, polygenic risk. And we don't know all the genes that are involved that might play a role in creating that risk. But I think that, I think people who, maybe adult onset obesity might be just like a form fruste of childhood obesity, or just, your genetic drive isn't as strong as if you develop obesity as a child, but your genetic risk is still there and your genetic drive is still there. But again, that's probably more my opinion than accepted medical opinion. I'll be
Okay.
right at the end of the day. Don't get me wrong. 20 years from now, it'll all be right. It'll be exactly as how I said it. But right now, the rest of the community hasn't caught up. I'm just kidding.
So just more work to be done.
Right.
Well, and I mean, that leads to an interesting question. So I am a child of the '80s where parents probably said some stuff that parents today probably wouldn't say, but one of the things that was always like, "You just have baby fat, you'll grow out of it," right? So, that was one of the things that I heard often is, do children grow out of obesity?
No. And that's like one of the big myths that needs to be busted. So at least some data suggests that 80% of children with obesity at the youngest of ages, 2, 3, will have obesity as an adult. But if you have obesity as an adolescent, your likelihood of having obesity as an adult goes up to 95%.
Wow.
So and that's without treatment, obviously. So no, people don't grow out of their obesity. Now, obviously, if you have, there are different weight categorization, and then there are times during normal childhood development, where children are supposed to have more fat on their body, like normal. So there are periods of time where patients or people will have extra weight that they will then grow out of, but not if that extra weight is into the obesity category. That's for just normal, like toddlers before they walk often are chubby. And then they get up and start walking around, and all of a sudden they lose weight because they're cruising around and doing toddler stuff. And that's
Right.
normal, but it's not normal if that toddler is significantly outside of the growth curve where they're supposed to be.
Gotcha. Okay. One question too that especially those of us on the genetic side get asked about, right, is family history. So if you have parents that are obese, does that mean that they will have children that will also be obese? And maybe it comes back to that nature nurture kind of discussion as well.
Sure. It's never, so I always, again, one of my tag catchphrases. It's not nature or nurture. It's both. It's always both.
Mm.
And
Hmm.
frankly, it's always both for almost every disease, but but especially when it comes to obesity. And so the families that would come to my office that were always the most sort of confused, I would say, or maybe that's not the right word, that didn't understand why their child had obesity, were the families where both parents were normal weight and they have 4 kids, 3 of whom are normal weight, and the fourth kid has obesity. And all 4 kids play the same sports. They all eat the same stuff. They all live in the same house. And they would come in and they'd be like, we don't understand why. And I would say, okay, mom, dad, do you guys have any brothers or sisters with obesity? Or were your parents people who struggled with their weight? Because it's in one of your families somewhere. We just don't know where. And invariably there'd be like, oh yeah, my sister struggles with her weight, or cousin on my dad's side has weight issues. So it's not inevitable if weight issues run in your family, but it does mean you sort of have to pay more attention to it
Right.
and then, maybe speak to your pediatrician earlier or maybe just start healthy lifestyle stuff earlier. And I actually, when I'm harping on the health of young, either to be parents or young parents, I also talk about the modeling of behavior after the kid's born. Because if you're dealing, let's say you have obesity and you have a kid. Now, if your obesity is not being treated, your eating habits and your lifestyle habits are probably going to be different than if your obesity is being treated, which no matter what treatment option you choose. So, and your kid, maybe not at 1 or 2, but once your kid's 3 or 4, they're noticing what you're doing and they're starting to model your behavior. And a lot of eating behavior gets sort of initiated by 5 or 6. So it's another reason for me, anyway, to tell folks you really should think about your own health, both before you get pregnant, couple, while you're pregnant, and then early after you deliver that kid, because that's when you're going to make the biggest impact on that kid's long-term health when it comes to obesity.
And you had mentioned that there are some, what we said, like single gene Mendelian genes, where, if you have this mutation, it goes along with having obesity as a sign. But usually there's some other things also at play. It's not just weight related. But then we talked about that there might be a combination of how different genes express themselves. I have seen some tests being advertised for genetic testing for obesity. Is that really testing everything? Is that really looking at everything? I mean, how accurate is
Yeah.
some of that?
So it depends on which test you're talking about. But obviously, you can get through, actually through your insurance, if there's rationale, there's medical reason to, you can get testing for a couple of the single gene defects, leptin deficiency for one. One of the reasons you can do that is that there's actually now a medication called setmelanotide, which can treat some specific single gene defects. And the company's obviously trying to figure out more gene defects that it can be used for, because obviously it's hard to make money if you can only treat very rare diseases as a pharmaceutical company. And that company actually, through a partnership, offers other genetic testing that, I believe that panel is now about 100 or so genes. Used to be only 30. So that tells you how things have changed over even just a short period of time. And a lot of those genes that they're testing for, we don't really know exactly what they do or exactly how they impact overall obesity risk. But obviously, if you have 3 variants, maybe they add up to something, maybe they don't, but it gives you some idea. But certainly we don't test for everything that could be involved because we don't know everything that can be
I don't
involved
know.
yet.
Yeah.
We're not quite there yet. Maybe we'll get there someday, but we're not quite there.
In your clinical practice or currently, are there, should some children have genetic testing or are recommended, or is it just when you're considering a very specific medication like the one you mentioned?
Yeah. No, I actually recommend. So again, this particular 100 gene panel used to be, and maybe still is, haven't checked recently, but it used to be free for patients if they met certain criteria, such as obesity at a young age. So for my patients, I could get it fairly easily. And I used to get it pretty routinely in families either where the obesity was particularly early onset, 5-year-old, 6-year-old, or if it ran in families really, like if everybody on both sides of the family had struggled with obesity, I would get it then as well. And I actually had about, at my best, I had about a 50% hit rate. So about half my patients actually had a, variant on this panel. And actually the company when it came to me and asked me like, how come you're so good at predicting who's going to have a positive test versus all our other clinicians who are closer to like a third or 20% success rate. And it's just because the patients who I would see, right? I'm a bariatric surgeon, pediatric
Right.
bariatric surgeon. So I was seeing a particularly at-risk group. There was no magic in my decision-making, or at least not any magic I would share with others. But I didn't necessarily know what those genes would do, but I did know that it would make the families feel better because they would understand more about, okay, this really is something that runs in my family or something that my kid is genetically predisposed to. So it did alleviate a lot of the self blame and self shame. And or parental blame and shame. And it doesn't necessarily change the treatment options, but at least in my mind, I would often tell folks that it might change the aggressiveness of your treatment recommendations or pursuit. Like I would tell folks, listen, you have two of the genes that are on this panel. Yes, we can start with behavior modification, but the likelihood of that working is probably lower based on your genetic testing results. But you need to be in charge of your own treatment plan. So it's just more information for you. But if you're asking me for my recommendation, I would recommend you be more aggressive because of the genetic results or genetic
Mm,
testing
okay.
results.
So it's one of those, again, you'd kind of pull into the overall discussion, looking at all the factors, and then as a physician, making recommendations or having that conversation with the family about the options. So there's not necessarily you order a test and it's like, boom, here's the answer and here's what
Yeah.
you do.
Unless you identified the single gene defects that could be treated by setmelanotide or would qualify for a clinical trial with setmelanotide, that might change.
Okay.
And that's obviously why the company would offer the free testing is because they're looking for patients to enroll in trials. And that did happen from time to time, but most of the defects were not eligible for trials. Most of the time, most of the times the results did not change the treatment recommendation
Hmm.
too much.
Right. But they would give some additional
Yeah.
information, I think,
And again, I think
probably
the
for the
days of,
conversation.
I hope that the days of doctors telling patients what they should do are going by the wayside, and it's becoming more of a shared decision making model.
Hmm.
So I would try to embody that by just giving patients information and then saying, here's my opinion, but you need to be the one, you and your kid need to be the ones making this decision. And this is just more information to put into that decision making process.
Got it. We've talked about the genetics of obesity or kind of, does this make somebody more at risk to be obese or maybe have a condition like diabetes? Are there any types of genetic factors that make it harder for somebody to lose weight? So, like having a slow metabolism or anything like that?
So that's a great question. And that's the short answer to that is I don't think anybody knows. But
Okay.
the long answer is that there are, so in my personal research history, we've done at least one study where we looked at patients who either didn't lose enough weight after bariatric surgery or lost enough weight but then regained weight to get on a GLP-1 medication. And this was actually before semaglutide was widely available. So it was with its predecessor, liraglutide. So the weight loss wasn't as much, but same GLP-1 mechanism. And one of the interesting findings from our study, which was the study was done at the NIH and was very well controlled or well executed study. One of the findings that was sort of important in my mind was that the folks who didn't lose enough weight after bariatric surgery were more likely to not respond to the medication. So to me, that is a biology problem that you're not responding to surgery and you're not responding to this particular one medication that almost certainly has to be driven again by individual variability, which is code word for genetics or epigenetics, because the drug worked better in those who had lost weight during after surgery but then regained it than it did in patients who never lost enough weight to begin with. So to me, that was a really, again, we didn't
Yeah.
necessarily highlight that finding, although we mentioned it and had a figure in the paper about it. But to me, that's a real sort of head scratcher because that's, again, to me, it's biology. So like, and could it be both ways? Could it mean that if you don't respond to semaglutide, but you do respond to tirzepatide, then you'll be likely to respond to surgery? Or does it mean if you don't respond to semaglutide and you don't respond to tirzepatide, your surgical response is also going to be less? We don't have other options necessarily, so it doesn't necessarily mean that we're going to change the treatment recommendations, but it'd be really valuable to patients to be able to tell patients, listen, you didn't do so well on these meds, and now we're going to surgery sort of as a last resort. So don't necessarily expect that your surgical outcomes are going to be the same as what you read in the literature or your neighbor down the street got from their surgery. because your biology already is behaving differently. And maybe that means that your biology is more refractory to weight loss strategies than your neighbor. So again, I may be I may be too much in favor of the genetic and epigenetic paradigm, but I really don't think patients sort of sabotage their own surgeries or sabotage their own weight loss medications because I just don't see what the secondary gain would be from that. So I don't know why patients would do that. So I'm always trying to figure out the biology. And like I said before, even if they do self sabotage, I think that there's probably a genetic mechanism behind that self sabotage because if you had free will, why would you sabotage your own health? Like it doesn't really make sense to me.
Right, right. Because some of these are fairly involved treatments, especially when you get to surgery, that come with their own risks and benefits and that potentially are not inexpensive for some of these.
Right. Again, why would you subject yourself to a general anesthesia and a life altering or an altering procedure just to, on the back end, go out and make it so it doesn't work as well as it could? Like, again, I think that the patients that do end up not following the postoperative plan, again, I don't necessarily think they do that out of their free will. I think there is something genetically driving them. I think there's something in their hypothalamus that is driving them to go back to the sweetened beverages or whatever it is that was their weakness before.
Well, and I guess that would be the next question is, and you've covered this, but it's is there a genetic influence or other things I guess that we're unaware of that influence cravings and appetite control?
Yeah. I mean,
And do you notice a difference between kids and adults potentially too in terms of cravings or appetite control?
yeah. So I think it's really interesting because obviously there's a lot of talk about how the GLP-1s work by reducing food noise, which is a new term that no one even knew what food noise was until
Yep.
these
I would say
medications
it was
came
new to
out.
me.
Right.
Yeah.
But if you talk to patients who've had bariatric surgery, they often tell you that their sense of smell is different and their sense of
Huh.
taste is different. Which
Hmm.
is another super fascinating piece of the bariatric surgery puzzle that no one's really figured out. But I've had patients tell me that, before surgery, milk was like something they drank 10 times a day. And after surgery, they can't even be in the same room with someone who has a glass of milk because they can't stand the smell of milk. So there's a lot we don't understand still, obviously. But, um, I think that there are likely, whether they're epigenetic modifiers or genes that put you at risk, or again, like the forever chemicals or pollution, air pollution is a big factor that people talk about now. I think there's still lots of pieces of this puzzle that we don't understand. And I think that the interplay between the genetics and the environment, food environment, inhaled environment, plastics exposures, which basically is the field of epigenetics, I think that's probably where most of the money is. Like, probably most of the explanations, again, go back to the not nature or nurture, but both paradigm where, yes, it's the environment. And yes, many ultra processed foods are really bad for us. And the way that they're bad for us is they might be causing food addiction in the brain or other brain changes, dopamine signaling, et cetera, et cetera. But they're also modifying the genes that we have and making it so that the whole weight management process is harder. And I actually should explain there's one study recently that has suggested that fat cells have quote unquote memory. And that's through epigenetic modification as well, where even after a weight loss intervention like surgery, the fat cell function, because of the epigenetically modified genes, still behave as if it's fat that has come from a person with obesity. And that might be what drives some of the weight regain after surgery or after medication cessation because as you know, about 80% of people after they stop their GLP-1s will regain weight. So again, to me, it's really super interesting. And it might only be interesting to me, but it is interesting to me because there's so much that we don't know. Like when I started doing what I was doing, when I started treating children with obesity 20 years ago, I didn't really know much about anything other than, sort of the basics. And now that I've spent 20 years of my academic career focused on this disease, I know a ton more. And I also now realize there's a ton more that I have no idea about. Back then, I just didn't know what I didn't know, which is, what happens. And now I know a little bit more about what I don't know, and it's still a boatload.
Yeah. Yeah. Well, and it's so again, this is an area that I didn't have much exposure to in my genetics training because, I mean, I don't even know if we were getting to it. We didn't even have polygenic risk scores, like we were just offering testing for
Yeah,
some things now that seem much more commonplace. And it's as you kind of keep peeling back, there's more there. So again, it's not as simple as willpower or like you said, free will, there's
yeah. I mean, I think that part of the equation, like, I think I pretty well understand now what will happen to a person, young person with obesity who doesn't get obesity treatment. Like now, I think we have enough longitudinal data that will show you patient will carry their obesity to adulthood, and they will have, earlier morbidity and earlier mortality if their obesity goes untreated as a child. So I think that piece of the puzzle or that part of the equation, we now have a much better handle on. What we don't know still is, although we're knowing better, is, how the different interventions work. We have no idea which intervention we should necessarily start with or propose to an individual patient um, as their initial therapy, other than diet and exercise, which everybody gets.
Mhm.
But I think that's sort of where the new science might be leading us, which is like how best do surgery and medications work together. And I kind of liken it to you're talking about cancer, polygenic score, risk scores in cancer. I do kind of make the analogy to cancer treatment where no one talks anymore about surgery or chemotherapy unless it's a particular disease like a blood cancer where surgery is not an option, or a particular early stage cancer where a surgical resection can cure it without chemotherapy. All the science is now about surgery plus chemo. Which chemo? What regimen? Pre-surgery, post-surgery, or both? And what is just the combination that's likely going to give the patient the longest remission or possibility, and what to do if it recurs. And so I'd like to think that obesity is moving in that same direction where we're going to stop talking about, your GLP-1 or surgery, but we're going to start to talk more about, okay, here's your genetic risk score. Here's your polygenic score. Here's your other risk factors. Here's the likelihood that medication is going to work for you if it's done in isolation. Here's the likelihood that your medication is going to be followed by surgery. Here's your long-term likely remission rate if you get surgery and a GLP-1. I just that's I think that's what patients want, and I think that that's where we need to go, because I think anything else is just sort of I don't know. It's just sort of, it sort of plays into the whole us versus them, or the whole I'm a lifestyle medicine doctor, so you are going to get lifestyle medicine and lifestyle medicine alone. I mean, it's just, like I now, although I was a pediatric bariatric surgeon, I'm now a pediatric weight management doctor offering both surgery and medications, because I've realized that the disease doesn't make choices, right?
Right.
The disease is just a disease, and you as the clinician have to help families navigate the choices that are available for them, uh, the most information they can possibly have. So I've
Right.
sort of changed
Right.
my tack
And
on that.
personalize the treatment for the person in front of you because there like you said, there are gonna be these different factors and the ways that they play a role. Some factors may weigh more heavily in one person, but not as much in the other.
Yep. Yep. So anyway, that's where I'm trying to help others maybe try to get to that same place where,
Right.
and I think maybe sometimes it's easier in kids because there's just less sort of dogma out there about kids, and people tend not to want to blame kids for their disease. They might blame their parents, but they don't really want to blame the kid themselves. They shouldn't blame either.
Right.
So, I guess I'm trying to start in the pediatric world, hoping that that might change how the adult world sees the similar situation.
Got it. Got it. And is there any types of resources or support that you guide parents to? Anything that like
Sure.
our listeners could check out if they had
Yeah.
questions or concerns?
Right. So first I would tell your listeners, no, I wouldn't tell your listeners because I don't tell anybody anything. I would suggest to your listeners that if they want more information, that two places that they can get a lot of free information on these topics are my YouTube channel, which is at Obesity Explained, or my website, which is www.obesityexplained.com. And I believe from my website, You can actually email me a question if you have questions, and I'm happy to point you to what resources there are that are available. But the reality is there aren't a lot of resources available, which is why I'm doing what I'm doing. And I'm trying to, like there's no clearinghouse for pediatric weight management programs in the United States. So if you went
Yeah.
online today and said, weight management programs available in the Northeast, you might get one or two that who've bought good AdWords on Google or whatever your search engine is. Or if you're a contemporary person and actually just use Gemini or Copilot or ChatGPT, you might get more. But there is no like one website you can go to where it lists all the programs in America for either medical weight management or surgical weight management for kids. And I don't believe there's one for adults either. There's certain websites that have some of it, but nothing comprehensive. So the unfortunate reality, especially for children, is that access to care for weight management is really difficult, which is why I started this pediatric telemedicine weight management practice so that people from any state can just, instead of having to find a brick and mortar clinic somewhere or hospital somewhere, they can just do it remotely. And I think while telemedicine won't solve all the access problems, I think there are some hybrid option of brick and mortar and telemedicine. And I think we just have to evolve as sort of a healthcare community because, patients in rural America, for instance, can't drive 2 hours to go to the nearest urban center to get weight management because it's just too hard, like with everyday life to do that kind of stuff. So, other mission of mine in my last, 20, 25 good years of brain function I have left. I'm going to try to fix that problem as well. I got a lot of things on my plate that I need
I
to
was gonna
fix.
say you have a pretty long to-do list.
Well, they say that all the longevity docs and all the longevity stuff says that you have to the more you stay active and engaged, the more likely you are to live a productive, healthy, long life. So I'm
Yeah.
trying to strive to that piece.
Well,
And
I mean, and it also sounds like there's a lot still to be done to this area. Because, like I said, just, even how this conversation has changed over the last 1 to 2 decades, I think is very different, right,
yeah.
than
So
how
when,
it was.
when I started doing bariatric surgery on kids over 20 years ago now, in one of my favorite stories is at an early professional society meeting where I was actually an invited speaker because I was doing trials of what was a device called the lap band, which isn't really even used anymore. But I was doing a FDA-sponsored trial using lap band in kids to see if it was a reasonable weight loss option. And so I was invited to give a talk at a fairly well-known medical society. And I presented my data to a room full of um, pediatric providers, or maybe adult providers, actually. Both probably were in that audience. And truly, like the first guy to get up and ask a question called me a monster, or maybe not, maybe he didn't use that word, but I felt like if he could have thrown tomatoes at me, which again is old school, I don't think anybody does that anymore. I was not a welcome person in that auditorium. And they basically asked me questions like, how do you sleep at night offering bariatric surgery to children? Like, that's so, out there. And, my answer would always be just spend a day in my clinic and you'll understand because these patients are desperate and they've tried all the things that you're telling them will work and they haven't. And I'm helping these kids immeasurably and they're forever grateful. And now 20 years later in 2023, the American Academy of Pediatrics has now included bariatric surgery as recommended down to age 13 in their clinical practice guidelines. So, that's why I started by saying, 20 years from now, I'm going to be right. Because 20 years ago, when I was offering bariatric surgery to kids, and everybody was calling me all kinds of names, and I had the courage of conviction. I knew the science and I knew the clinical scenario, and I knew that what I was doing was at least ethically responsible and at best was going to help a lot of kids.
Well, and you were doing it too as part of like a clinical
Right.
trial.
Right. So if it
Yeah,
didn't
so
work
was
out,
it
right. So if it didn't work out, at least we'd have the information that it didn't work out and that we should not be offering surgery to kids. Although, again, obviously I did not have equipoise. I was convinced it was going to work.
Mhm.
Supposedly, to have the best clinical trials, you're supposed to have no bias towards whatever outcome you're going to have. Couldn't, I could not, I couldn't not have a bias. I had a bias. Yeah. But anyways, 20 years later, we've learned a lot about the disease. We know how to treat it better. Medications are actually also part of the AAP, the American Academy of Pediatric guidelines, down to age 12, surgery down to age 13. I've actually used both medications and surgery in kids younger than 12, and actually have published on that topic as well, because I've done more bariatric surgery in kids under 12 or under 13 than anybody in the country. And again, those are usually genetically driven, sometimes single gene, but often polygenetically driven patients. So there's still lots more to learn and lots more to do. And science is ever evolving, and hopefully people keep open minds to the science. And, science isn't always, sometimes the science that evolves or the science that's done actually tells you that the old way was actually the best way. Like, my study could have easily shown that bariatric surgery didn't work in children, and then we would know, and then we wouldn't offer it to them. So science doesn't always have to provide new findings. Sometimes it can just confirm old findings. But especially in this day and age of what I like to call the misinformation superhighway of social media, it's important that people continue to do science and continue to look at it critically, whether for obesity or any other disease, because we as the clinicians are we're like the last stand. We're like the last, whatever. We're the ones who actually see the patients and make the recommendations. So we have to have the science to know what to recommend. And this is a little bit of a soapbox, and it's obviously more pertinent right now because of the vaccine scheduling and acetaminophen causing autism and all these other things that are really not scientifically backed.
Right.
Same goes with obesity.
Hmm.
Yes, ultra-processed foods are bad for you, but don't believe that they're the only thing causing obesity in America. It's just way more complicated than that. And obviously genetics play a huge role.
Yeah. Yeah. And I think that's why it's been a fascinating conversation. I've learned a lot, and why I was excited to have you on, because again, I think it's one of those things where either people don't give it much thought if it's not something they've encountered, or what they find is an oversimplified explanation or attempt at an explanation. And since we've covered quite a bit, I mean, what is the one thing that you would want parents to take away about childhood obesity from this
Yeah.
conversation?
Well, first of all, thanks for having me. And I the time here, and obviously always happy to come back. Obviously very passionate about this topic, and especially the genetic aspects of it, or epigenetic aspects of this topic, because I think those, so there's something called the intergenerational transmission of obesity, which I sort of alluded to earlier, but I think that's actually the key to this whole obesity epidemic, is figuring out a way to keep parents from passing it on to their kids. And that's not just genetics or epigenetics, but it's also behavioral. And so what I would tell parents, if you're concerned about your kid, go see your pediatrician or your provider, if they're a family practice doc or a nurse practitioner, whoever they are. Go see your primary care provider, tell them about your concerns. Hopefully that person can point you in a direction to get more information or more care if that's what you're looking for. But unfortunately, that's not always the case. You might have to do some digging on your own, which again is unfortunate. But especially in my early days of pediatric bariatric surgery, lots of the families and often the kids themselves were the ones who found me on the internet, and then they had to convince their parents to let them come see me. So you might have to do some digging. My website, YouTube channel are places where you can get some of that information. Although you have to email me from the website if you need specific places to be referred to. So I guess I would say self-advocate, and don't let society or providers or anyone tell you that it's your fault or that there's nothing you can do about it, because those are both inaccurate statements. And I would also say, stay hopeful, because you have the GLP-1s, but there's a whole new generation of GLP-1 biagonists and triagonists that are in development. The field of obesity is evolving quickly now. It was evolving slowly for a long time, but now it's evolving quickly. And so there are going to be options for you medically, surgically, and we'll learn more, and we'll learn more about genetic risk. And there's a lot of science going on right now, and a lot of, I'm hopeful for the future. I think that there are still things that we're going to learn that can help a lot of people. At least I hope so.
I think so. I mean, it's like there's quite a bit that has been done, especially in the last bit, but there is still more to come. And so, like you said, maybe we'll have to have you on again to get some additional updates and continue the conversation.
Yeah. Well,
But thank you.
when my book finally gets published on childhood obesity, which is probably going to be 2 years from now. So don't Nobody
Okay. Well,
hold their breath.
there we go. We'll
Nobody
set the
hold their
date.
breath, including me. But, uh, but yeah, I'm happy to, and obviously, if there's a big genetic development or an epigenetic development or anything, I'm happy to come back. I'm happy to come back anyway, just because there's always. I mean, we've spoken for about an hour, but there's, I
More
could
to
talk.
talk about,
Oh yeah,
honestly.
I could talk
Yeah.
about
Yeah.
this
A lot
topic all
more.
day, and we haven't even gotten into adverse childhood events or other issues that are likely, again, sort of epigenetic modifiers. We could probably do a whole episode on epigenetics, but then I'd have to read a lot more because there's so much still unknown about that I'd have to get caught up to date on the latest because that field is also truly evolving quickly right in front of our eyes.
Yes, definitely.
But again, happy to continue to try to advocate for people, people with obesity, people with children with obesity, all of the above, because I think we need more advocates out there. So I'm trying to lead by example a little bit.
Thank
Hopefully,
you. And thank you for being on the show today. Like I said, it was great to have you.
yes. Again, my pleasure, and I'm happy to come back anytime.
For more information about this episode, visit allaccessdna.podbean.com, where you can also stream all the episodes of the show. Any inquiries on the podcast can be sent to allaccessdna@gmail.com. Please rate and review the podcast on Apple, Spotify, YouTube, or wherever you listen. This helps other people like you discover the show. Note that this podcast is for entertainment and education and is not intended to be a substitute for professional medical advice. Please consult your physician with any questions you may have regarding your health. All Access DNA is an independent podcast hosted and produced by me, Kate Wilson. Designs by NKJ created the logo. Thanks for listening and join us next time.